Good morning, guys. I hope you are doing fine. Well, today I will be discussing refusal structure. What do I mean by refusal structure? In your PLAB 2 exam, one of the cases, one of the OSCE, okay, will be a patient who is refusing something. Refusing something? Yes. So, when you open the cubicle, when you confirm your name and then you confirm the patient name and date of birth, the patient will be refusing something. Dr. Mo, and is that an OSCE in the exam? Yes, refusal structure, okay? So, don't forget that in PLAB 2, we have to address the patient concerns, right? We all know about addressing the patient concerns. Yes, Dr. Mo. In this case, the patient concerns will be, I am refusing such and such. I don't want such and such. For example, I want to go home, refusing admission. I don't want to stay admitted in the hospital. For example, I don't want such medication. For example, I don't want you to do such a procedure. For example, I don't want you to do colonoscopy. Okay, so there will be something that the patient is refusing. For example, a patient is getting treated with chemotherapy. No, I don't want chemotherapy. For example, a patient who has breast cancer getting treated. I don't want to treatment for breast cancer. So please, it is called refusal structure. So what is the patient main concern here is refusing. So please forget about everything. Forget about everything. Focus on the patient main concern, which is the refusal. So I will have a structure for all cases. When the patient is coming to you and refusing something, I will have few steps, and after doing these few steps, my job is done. By the way, I just want to agree on one of the concepts. If you have a case where the patient is refusing something, do you think you have to convince him? No, you do your best. You follow the steps. But if the patient is not convinced, it's okay. That doesn't mean that you will fail the station. So after following your steps, if the patient is still refusing, it's fine. Because some doctors think that in this kind of cases where the patient is refusing something, I have to leave the cubicle convincing this patient with this thing that I came for. No, that's not right. So you do the steps, you follow what I'm gonna tell you. If the patient is still refusing, it's fine. So number one, if the patient is refusing something, what to do? Number one, I will ask him why. So why? Why are you refusing such and such? For example, if the patient is refusing admission, may I ask why are you refusing admission? The patient will give me a reason. The patient will give me a reason. Yes. The second step is trying to address this reason. Address the reason why. The reason why he is refusing. What do you mean, Dr. Mo? For example, a patient wants to go home. He's refusing admission, okay? Then you asked him why. He said, because I have a cat to look after. So what's his main concern? Why? Because the reason is he has a cat at home to look after. So the second step is me addressing the concern. Me trying to solve the problem of the cat. For example, telling him, do you have neighbor nearby? Anybody lives with you at home? Any neighbor nearby can look after the cat? Any relative nearby who can come and look after the cat? And if there is nothing, then there is the RSPCA, which is Royal Society of Cruelty Against Animals. So it's a society where they can look after animals. For example, addressing his main concern. No, the patient is still refusing. After addressing his concern, for example, no doctor, no, I don't want to look after my cat. Or may I ask why you're refusing admission? The reason, I have wedding to plan. My own wedding I'm planning. Congratulations. And then you can tell him, can anyone else help you with that? Your partner, relative, you understand? Close friends. No doctor, I don't want, I want to do it myself. So step 2, which is addressing the reason why, still not working. So step 3 is assess his knowledge. Assess his knowledge. His knowledge about what he has. What do you mean, Dr. Mo? Assess his knowledge about the condition that he has. Mr. Alex, Mr. Andrew, do you know what you have? Do you know the condition that you are having? In this case, I'm trying to make sure that he understands what he has. For example, if the patient is admitted for DKA, for example, if the patient is admitted for bowel cancer, so I will tell her, do you know what you have? Well, doctor, yes, I do. I have bowel cancer. Or, yes, I do. I have diabetic ketoacidosis. Yes, do you know? Assessing his knowledge. So then you will say, do you know what DKA is? No, doctor. Then explain what you, as a doctor, explain what DKA is. So assessing the knowledge is basically trying to make sure that the patient knows about his condition for which you want to admit him, or the patient knows about his condition for which you want to give him treatment. So step four, after assessing knowledge, what if I'm assessing the patient knowledge and he or she don't understand? What to do? Explain. So in step 3, when I say assess his knowledge, assess the patient knowledge about his condition. Do you know what you have? If the patient doesn't know what to do, explain. In brackets, explain. Now, step 4 is risk and benefits. That's step 4 and 5. Risk and benefits. What do you mean by risk and benefits? We need to admit the patient. We assess his knowledge. He knows what DKA is. Step 4 is, do you know why we need to admit you? What are the benefits of keeping you in the hospital? So step 4, in which I will discuss about the benefits of keeping you in the hospital, or the benefits of treating you, the benefits of doing colonoscopy, the benefits of, for example, giving you chemotherapy. So step 4 will be the benefits of the thing that I want to convince him with. Do you know why we're doing this? Do you know why we're admitting you? For example, DKA, why we're admitting you? Because we need to give you fluids through your veins. We need to give you some insulin through your veins because your blood sugar is high. So benefits of what you're talking about. Still, he's not convinced. Step 5 will be, I will go through the risks. The risks of refusing. What do you mean, Dr. Mo? The risks of refusing. For example, he's refusing admission for DKA. What are the risks? Number 1, death. It is life-threatening. It is life-threatening. So, it is life-threatening condition. So, if we don't keep you in the hospital, I'm afraid it can lead to serious consequences. So, step 5, in which I will be talking about the risks of not doing what I want the patient to do. For example, if the patient is refusing colonoscopy, for example, we are doing colonoscopy to check for bowel cancer. The risk is what? Missing an important diagnosis, missing a serious diagnosis, maybe, which will lead to serious consequences if we do miss it. So risks of refusing whatever. And in brackets, in these risks, I will write in brackets, scare the patient. Scare the patient. What do you mean, Dr. Mo? Scare the patient. If the risk is life-threatening, tell him. Don't be shy. It is life-threatening. So scare the patient. So the risks of refusing, and in which I will scare the patient. Step 6. The patient is still refusing after you even scared him or her. So step 6, escalate to senior. Escalate to your senior. Maybe he will be able to talk to you. So I will tell my patient, what do you think of escalating this to my senior? So maybe he will be better in explaining things. What do you think of escalating this to my boss, to my senior, when he will be actually able in a better position to explain this in a better way? So escalate to your senior to talk to the patient. Step 7. No. I don't want you to escalate. I still don't want. Step 7 is discharge. Discharge against the medical advice form. So I will ask the patient to sign a form which is discharge against the medical advice. So the patient will have to sign a form which is called discharge against the medical advice. Final step, I will still safety net the patient. Safety net the patient. Dr. Mo, what do you mean by safety net the patient? It doesn't mean that the patient is refusing whatever. It doesn't mean that the patient, yes, he doesn't want, yes, she doesn't want, and you will send the patient home because she doesn't want the admission, that you will neglect the patient. No, you will still safety net. safety net the patient for his condition. For example, if it's DKA, so you will say, okay, when you go home at any time, you feel yourself, for example, dizzy, drowsy, at any time you feel yourself so lethargic, at any time you feel, ring 999. So always safety net the patient for his condition. Always safety net the patient for his, doesn't mean that you sending him or her home and they refusing what you're gonna do, so you don't safety net the patient. You will still safety net the patient. So we'll start now by discussing the cases, and all these cases, all the branch today will be about patient refusing something. How do I start? I will start by asking why. The patient will give me a reason. Step 2, I will try to address the reason. The patient is still refusing. Step 3, assess the knowledge. How much do you know about your condition? And under this, how much do you know about your condition? Assess knowledge, how much you know about your condition. You will explain, you will take advantage of explaining the patient condition. Then step 4 is the benefits. Do you know why we want to give you this? Do you know why we want to keep you here? No benefit. Do you know what will happen if you are refusing this? No risks. Tell him the risks. Okay, and then is it okay if I talk to my senior? Maybe you'll be able to convince you. No, still refusing. Discharge clinical advice, and I will still safety net the patient. What if when I am going through the refusal structure, I've asked why, he gave me a reason. I started to address the reason. He was happy. He was happy. Then what to do? Should you carry on with the rest of the structure? Of course, no, because this structure is, when I go to further step, it's because the patient is still refusing. But at any step the patient accepted, then thank you very much. Okay? Then start taking history. It becomes as normal station. For example, DKA. If the patient at this step of addressing why he accepted, then is it okay to have a chat about your condition? Then start taking history, then management. Okay, so it become as a normal station. So I only carry on with the steps if the patient is still refusing. But if the patient accepted at one of the levels, stop, it becomes like a normal station. So in refusal structures, I will discuss few stations. Number 1, a patient who is refusing warfarin. A patient who is refusing warfarin medication because he is thinking that it's a rat poison. Station number 2. A patient who's infective endocarditis, refusing admission. She wants to go home. Step number 3. A patient who's hypoglycemia, refusing admission. Step number 4. Pneumonia, patient refusing treatment. A patient who has pneumonia, refusing treatment. Step number 6. Cancer patient refusing chemotherapy. A patient who has cancer refusing chemotherapy. Station number 7. Breast cancer refusing treatment. Station number 8. Patient refusing colonoscopy. Station number 9. Prostate cancer refusing treatment. And then the refusal structure has finished. So have you noticed something, that all these patients are refusing things critical? What do you mean, Dr. Mo? A patient who is refusing a cancer treatment. A patient is diagnosed with cancer and refusing cancer treatment. I just want to grab your attention to one thing. What is the thing, Dr. Mo? If a patient is refusing something, we always say that the patient has to right to refuse as long as he or she has mental capacity. What do you mean, Dr. Mo? I'm 35 years old. I have mental capacity. If I refuse something, I have the right. Nobody can force me to refuse something as long as I have mental capacity. Oh, so the patient can refuse as long as they have mental capacity? Yeah, they can. So follow the structure. If he's still refusing, he can as long as he has mental capacity. How do I know that the patient, Dr. Mo, has mental capacity? What is that meaning of mental capacity? As simple as, if the patient knows about his condition, if the patient knows the benefits of which you want to do whatever, you want to admit him, you want to give him this, if the patient knows the consequences of refusing, the risk of refusing, that's what we call it, he has mental capacity. So mental capacity, the patient can refuse anything as long as he has mental capacity. And how do I know that the patient has mental capacity? From step 3 and 4 and 5. 3 is assess knowledge. Yes, he knows about his condition. 4 is benefits. Yes, I told him about the benefits. 5 is risk. Yes, I told him about the risks. So if the patient knows about the condition, the risks and the benefits, and he can retain the information, he can take the information, and he can repeat it for me again, That means that he has mental capacity. That means that he has the right to refuse. I want you to know this thing because some of you guys think that my job here is to convince him. If I didn't convince him, I fail. No. Some people think that the patient has to accept. No. As long as the patient has what? Has mental capacity. What do I mean by mental capacity? He knows what's happening. He understands. You tell him and he retains the information and he can bring back the information to you, then the patient can refuse, okay? There is one more word. So that was a small brief explanation about what is mental capacity and does the patient have the right to refuse or not. Okay, the patient has the right to decide everything about his or her management plan. Yes, they have. The second thing is, if a patient is refusing cancer treatment, if I am a patient who has cancer, okay, and I'm refusing cancer treatment, you spoke to me about the benefits, I know the benefits. You assess my knowledge, I know my condition. You check my understanding, I know everything about the condition. You talk to me about the risk, yes doctor, I know I'm gonna die if I don't take the medication, but I still refuse. Would that doesn't take you to a point which is you trying to assess the patient mood? Maybe the patient is suicidal, because knowing that if you refuse such a medication or if you refuse such a procedure, you're gonna die. Maybe there is another reason here. Maybe it's an old patient who's getting abused at home. That's why he is refusing. He wants to die. So if you tell the patient that risk is life-threatening, it can lead to death, and the patient said, yes, I know, I don't care, then you can ask about the mood. Nobody wants to die. If you tell the patient you will die and the patient is accepting, if you don't take this and yes, I'm gonna die, it's fine. Assess the mood. How is your mood? How do you feel? Who do you live with at home? Is everything okay at home? Is there anything you think we can help you with? So please, have you discussed this decision? Would you like to discuss it with any of your relatives? Why? Because it's like a suicide. So please, in these cases, I will put in a heart at the end, in a heart, assess the patient mood, assess the patient mood, assess the patient mood, assess the patient mood, ask about psychosocial, so mood and psychosocial, because the patient can be suicidal. So all the cases will be around what I'm talking about now. So the first case is, you are an FY2 doctor in the medical department. Mr. Alex Wilson, 55 years old, was admitted 4 days ago with palpitation, heart racing, and he is diagnosed AF. He's about to go home on warfarin. So the patient presented 2 days ago, heart racing. He is diagnosed now AF, atrial fibrillation, and your consultant asked you to go and talk about warfarin because your consultant prescribed for him warfarin. So you will go confirm identity. Hi, I'm Dr. Fatih Al-Bab, one of your doctors here. Can you please confirm your full name and date of birth? The patient will confirm the full name and date of birth. Before I start my refusal structure, before I start my station, before I talk to, I don't know yet, will he refuse or not? Don't be scripted. Do not be scripted. The question did not say he's refusing. The question said go and talk to him about warfarin. Before that, I will build a rapport. So before I start my structure, before I go with the patient, I'll build rapport. I can see from my note that you've been admitted 2 days ago with some heart racing. Am I right? Yes, doctor. How is it now? Do you still feel the same? Yes, doctor. No, doctor. How's the hospital stay? Was everything okay in the hospital? Yes. How's the care by nurses? How's the care by doctors? Yes, doctor, was really good, was really lovely. I can see that the consultant is discharged you, has discharged you. How do you feel about going home? Doctor, I feel happy. That's what we call it rapport. So I started building rapport. Rapport is, I can see from my note, use what's there. I can see from my note that you've been admitted in the hospital for 3 days. Yes, doctor. With heart racing, yes. How do you feel now? I feel good. I feel good, doctor. Okay, how is the hospital stay? How is the care by doctors and nurses? Good, doctor. So start your station now. Start your station. When my consultant has prescribed for you some medication which is called warfarin to take home with you, and I'm here to talk to you about it. No, doctor. Warfarin? No. No, doctor. I don't want warfarin, doctor. I don't like it. I don't want it. So he's refusing warfarin. Well, may I ask why, Mr. Andrew? I can see that you are reluctant to have this medication. May I ask why? He will tell you, well, doctor, this medication is rat poison, doctor. This medication is rat poison. It's like a medication that it has the same constitution of rat poison. So that's his reason. The reason is that it's like rat poison. Okay, before I go to the second step, which is addressing his concern, is it really normal for any patient to know that warfarin is like a rat poison? Is it normal? No, it's not normal. I think this patient has a background. I think this patient knows what warfarin is. Because even you as a doctor, maybe you don't know. So, is it normal? It's not normal. So, when the patient tells you something that will grab your attention, ask. May I ask, how do you know? May I ask, what's your background about warfarin? And it is rat poison, like a rat poison. He will say to you, oh, doctor, my dad. So the patient knows about warfarin because his dad was on warfarin. My dad was on warfarin, doctor, because he had atrial fibrillation and he was on this medication, and I know it's like rat poison. So how is your dad doing now? Ask about his dad. How is he doing now? Will he's good? Will he die? I'm sorry to bring this back, these bad memories back again. So forget about it, guys. Then I will move to the second step. I will say to him, address his concern. Why? So he's refusing. Why? Because it's like a rat poison. So I'll say to him, yes, warfarin has the similar component to rat poison. However, it is not rat poison. It is used for medical treatment. No, doctor, I don't want it, doctor. I don't want it. He's still refusing. Then I'll go to assess his knowledge. Mr. Andrew, do you know what you have? Do you know what you've been admitted here for? No, doctor. You've been admitted here because of a condition called AF, atrial fibrillation. So step 3 is assessing his knowledge. Do you know what atrial fibrillation is? No, doctor. Atrial fibrillation is a condition where your heart is beating irregularly. And this condition can lead to blood clots to your heart or lungs or your brain, which can lead to serious consequences. So now I'm trying to assess his knowledge. He doesn't know. I started explaining about AF. So explain about AF. Then the patient is still refusing. Then you will tell him, Mr. Andrew, do you know the benefits of us giving you this medication? So step 4 is benefits. No, doctor. Then you will start telling about the benefit. The benefit of the medication. Warfarin is a medication that will make your blood thin, so it decreases the incidence of blood clots in your heart or lungs and brain. So that's why it's mandatory for us to give you. When you tell him these benefits, he will tell you, yes, doctor, yes, I don't want it. My dad had the medication and my dad had a fall, and after falling, he started bleeding in his brain. So he will give you another cause, which is his dad who was on warfarin. His blood was too thin and he started bleeding. Then you will address it. You will say, well, that's right, that warfarin is a blood thinner and it can lead to the blood being thin. Yes, that's right. However, if we weigh the risks and the benefits, we will tell you that warfarin will prevent you from having these clots, which can lead to serious problem. And at the same time, we will assess you. We will assess you for any reason why you may have a fall. So we'll make sure that you don't have any reason why you can have a fall at home. Okay, that's why you will get the benefit of it. However, we will try to prevent the risks of falls. So you are basically telling him, yes, too much warfarin, or warfarin is a blood thinner that you can have a fall and you can bleed, but we will assess you for the reason why you might have a fall and will prevent it. Also, we will monitor what we call it INR. It's some blood tests that we will do to prevent your blood from being too thin. Now, he's still refusing. Scary. Do you know what will happen if you continue refusing the medication, or if you don't take the medication? Do you know what will happen? No, doctor. Then talk to him about the risks. You will develop blood clots. Okay, because your blood will be too thick. If these blood clots goes to your brain, it can lead to stroke, which is basically weakness in your body, permanent weakness, okay? And if this blood clot went to your heart, it can lead to heart attack, okay? And if this blood clot went to your lung, it can lead to what we call it pulmonary embolism, and all these conditions are life-threatening. If the patient is still refusing, do you mind if I talk to my senior? He can discuss this with you. No, still refusing, discharge against the medical advice, and then safety net. So always you make sure you safety net. Safety net. What do you mean safety net? You are giving him warfarin for AF and for blood clot. So always safety net him for AF. If you have any heart racing, chest pain, or if you have any blood clot, if you have any chest pain any chest pain or any weakness in your body or any leg pain, come right away. So safety netting is safety netting for his condition, which is AF and the complication of AF. So heart racing, weakness, any chest pain, any leg pain. Okay. The second case is infective endocarditis. You are an FY2 doctor in the acute medical department. Nicole Harrison, 24 years old, admitted a week ago with infective endocarditis. Admitted with what? Infective endocarditis. She's supposed to receive 3 weeks of IV antibiotic. Be careful, because this is the benefit or the reason why we're gonna put her in the hospital. She is supposed to be receiving 3 weeks of IV antibiotics. However, she wants to leave the hospital. Talk to her, address her concerns. Again, I will start the same station with everything. I will start by rapport. Hi, I'm Dr. Fatih Al-Bab. I'm Dr. here. Can you please confirm full name and date of birth? She will confirm full name and date of birth. I can see from my note that you've been admitted in the hospital here. Yes, doctor. How do you find the hospital stay? How is the care by doctors and nurses? Rapport. Build rapport. Then start. The patient will tell you, doctor, I want to go home. Doctor, I want to go home. Then you'll ask her, may I ask why you want to go home? May I ask why you want to go home? She will start, first of all, the patient will start giving you a reason for which she's going to be lying about it. She will tell you, well, the nurses are talking shit about me. Talking shit about me, talking bad about me. The nurses are talking shit about me. Well, I'm really sorry if you feel that way. Well, if this is the case, this is so she's giving you a reason, but in this case, she may be lying about the reason. So that's not the reason, actually. Well, I'm really sorry about that. So you are trying to address her concern. Well, I'm really sorry about that. That shouldn't have happened. That's unacceptable. I will have a word with them and the word with the ward manager and see what's happening. Is there anything else that's bothering you? Well, doctor, well, I want to go home, and she'll give you another reason. Well, they don't let me go out to smoke, and if I don't smoke, doctor, if I cannot smoke, I'm afraid I will go to my house. I don't want to stay admitted. I will go home. So another reason, she gave you another reason, because I said to her, is there anything else that's bothering you? She wants to go and smoke. Well, we'll say to her, well, Nicole, the hospital building, the hospital premises is a non-smoking area. So I'm afraid you cannot smoke in the hospital. You cannot smoke in the hospital. So the patient is saying to you, I want to smoke. You can address the second concern by, you cannot smoke in the hospital. It is a non-smoking area. However, I want to address your concern. While you're staying in the hospital, we can give you some nicotine patches. Some nicotine patches where it will help to give you the nicotine that you want in your blood, okay? But without taking or without smoking a cigarette. Then no doctor, no, I don't want these nicotine patches, no doctor, I don't want it. Then you can, again, as a part of addressing the concern, you can say to her, well, smoking, I'm afraid to come across the way, can kill, and smoking does affect the heart, and you have a problem, a condition in your heart, and if you continue smoking, that will lead to serious consequences. No doctor, if I don't go outside and have a smoke, I will leave the hospital. Then it's becoming either really let her go outside the hospital, have a smoke and come back, or let her die in the hospital. Or let her leave the hospital and die. So she's saying to either I will leave, and in that case she will die, or let me go and have a smoke and come back. You started talking to her about nicotine patches? No. You started saying to her that smoking can affect your health badly? No. If I don't go out for a smoke, I will leave the hospital. And in this case, guys, I wouldn't let her leave the hospital because she wants to have a cigarette outside, so she cannot smoke in the hospital. It's not a smoking area. I advised her about smoking. She still doesn't have it. Then, okay, she can go out for a smoke and come back, but I will tell her, all right, is it okay if we have a chat about your health? Is it okay if we have a chat about your health? And then we can let you to go outside the hospital, have a smoke and come back. Yes, doctor. Then start talking to her about her condition, which is assess her knowledge. So do you know what you have? Do you know the condition that you have? Do you know the condition that you have? Well, doctor, I don't know. Then you will explain to her infective endocarditis. It is a condition of your heart where the infection inside the heart muscle, there is an infection inside the heart muscles. So your heart has an infection, okay, which is basically a serious condition that needs to be treated. Okay, okay, doctor. Do you know why we need benefits now? Benefits. Do you know why we need to keep you in the hospital? No, doctor. We need to keep you in the hospital. Why? For what? Because we need to give you medications through your veins, which you cannot take it at home. So you cannot take this medication at home. So we need to keep you in the hospital to give you medication through your veins. Then, this is the benefits. Okay, and then go to the risk. If you go home, do you know what will happen? No, doctor, if you go home, it's life-threatening condition. So infective endocarditis is a life-threatening condition that can lead to sudden death. So infective endocarditis is life-threatening condition that can lead to death. Sorry, not sudden death. That can lead to death. So if we leave you go home and you don't take antibiotic, it can lead to death. Doctor, can I have oral antibiotic? Well, I'm afraid it is a serious condition enough to actually for you to be needing medications through your veins because it is more effective. So she cannot be in oral antibiotics. So come, tell her that now you spoke about the benefits, spoke about the rest. Now you want to go back to the smoking indirectly because she wants to go out and smoke. So go back to smoking indirectly. You will say to her, this condition, there are many risk factors for which a patient can have this condition. Is it okay if we have a chat and in this part, when you spoke about risk, benefit, knowledge, you will talk about the causes, the risk factors. The risk factors of this condition, number one, is IV drug abuse. So take history of IV drug abuse. So do you take, I'm sorry to come across that way, do you take any recreational drugs? If she said yes, so what do you take? How do you take it? And that's it. That's not psychiatry. What do you take? How do you take it? She will tell you, I inject heroin. Do you share needles? If she said yes, talk to her about needle exchange program. Number two, sexual history. So take sexual history. So sexual history and IV drug abuse in this case is a must because it is a risk factor. Now you will go to talking to this lady about smoking. That is smoking, but not in details. It's not smoking. Yes, smoking can really affect you badly. Smoking can affect your condition and it can harm you and it decreases the healing in the body and it does affect the heart as well. Okay, if she's still, no, okay. If you still, she's still refusing after you're talking about smoking and assess her knowledge and check everything, she has mental capacity well, definitely you can go and have a smoke. And then when you feel ready to quit smoking, tell us and we'll address this, okay? Now, safety netting is safety netting. So how to safety net the patient? You can safety net the patient by at any time you have a chest pain, at any time fever, at any time, you understand? You have heart racing, you can let us know or you can call 999. Station number 3, hypoglycemia refusing admission. Again, you are an F1 doctor in D&E. Daniel Smith, 25 years old, collapsed while doing shopping, brought by the ambulance, blood glucose level 2.1, talk to him, address his concern. So it's hypoglycemia station. Hypoglycemia. In all these cases, if you notice, it's all diagnosed cases. All these conditions are diagnosed because the reason why it is just a refusal structure. Okay? So, hi, I'm Dr. Fatih Bab, one of your doctors here. Can you please confirm your full name and date of birth? He will confirm his full name and date of birth. I will say to him, okay, I can see from my note that you have been brought by the ambulance because your blood sugar was low. Then he will start saying, I want to go home. That's his main concern. I want to go home. Well, may I ask why you want to go home? Then he will say to you, doctor, so please, if the patient is having a concern, address the concern. Don't go after what you want to go. Go after the concern. May I ask why you want to go home? Doctor, I want to go home, doctor, because I have a wedding to plan. I can't stay in the hospital. That's number one reason. He wants to go home because he's planning his wedding and he cannot stay in the hospital. Address the concern. Well, congratulations for your wedding. However, by any chance, do you have any friends that can help you with that? No, doctor. Well, do you have any? Always when you give the patient options, while you're addressing the reason why he's refusing something, give him the options that doesn't cost. For example, if he's got cat at home, don't say to him, society, the RSPCA, Royal Society of Cruelty Against Animals. No, don't give him things that will cost him. So in this case, I'm not going to say wedding planner. I'm going to say close friend, your partner, and then I can say wedding planner. If he's still refusing, I will assess his knowledge. Do you know what you're having, Alex? Do you know what you're having, Andrew? No, doctor, I don't know what I'm having. You have a condition called hypoglycemia. And then tell him about hypoglycemia. Do you know what hypoglycemia is? No, doctor. Hypoglycemia is decrease in the blood sugar in your blood. So the blood sugar level in your the blood sugar level is low. So decrease in the sugar level in your blood. So that's why we need to keep you in the hospital. I know, doctor, but I don't care. Do you know why we need to keep you in the hospital? Benefits. We need to keep you in the hospital because you need to have fluid through your veins that contains sugar, and that cannot be done at home. No, doctor, I don't care. Step 5. So do you know the risks of going home? Do you know if we let you go home, what will happen? What will happen, doctor? Basically, it can lead to sudden death. This condition can lead to sudden death. It is life-threatening condition. I'm afraid it is serious condition. No, doctor. So can you please repeat for me what I've just mentioned? Yes, doctor. You told me I have low blood sugar and I need to stay at hospital to have fluids and sugar. And if I don't, I will die. He knows. He knows how to retain the information. He knows how to give me the information back. He has mental capacity. Is that what you want? Yes, doctor. I don't care. I just want to go and plan my wedding. Now he's still refusing. I will talk to my senior. I said, is it okay if I discuss it with my senior so he can come and speak to you and convince you what's happening? Still refusing discharge against medical advice. Still refusing safety net him for hypoglycemia, which is hypoglycemia is low blood sugar. If you have it, you will have basically your body you will be irritated, you will feel hungry, you will be sweating. And anytime you have it, have something sweet, something sugary, safety netting. However, in this case, what if while I am telling the patient about the risks, when I told him about the risks, he was convinced. He said, oh, sudden death, I will die. No, it's fine. I will stay in the hospital. So he was convinced. So after telling him about the risks, he was happy to stay. So what will be my approach or what will be my structure? If he's happy to stay after I told him about the risks, then you can start by taking history. But focus the history. Can you please tell me what happened? Number 1, if he's happy now, if he accepted. So I will quick go through the history. What is the history? Diabetic history. Nothing else but diabetic history because it's an acute emergency. Diabetic history. I can see from my note that you are type 1 diabetes. Yes. Since when? Are you on any medication? What medication? Is it managed? Is it controlled? Do you measure it? And then ask about some complication like kidney problem, heart problem, numbness or tingling in the hand and feet, eye problem. That's it. Just before you had this collapse, what were you doing and what happened? To get the reason. Before this collapse, I was running around, doctor, and I didn't have my food and I injected myself with too much insulin. That's the reason. So it will be focus history. Number 1, diabetic history, which was discussed in diabetic cases. Diabetic question. Number 2, just before the collapse. What happened? To get the reason why he collapsed. To get the reason for hypoglycemia. And then go and say, okay, we'll start managing the patient. How? Start talking about investigation, hemoglobin A1C. So the steps. Admit number 1. Senior number 2. Step 3 is, we've discussed this in hypoglycemia, don't worry, but this is a counseling now. Step 3 is investigations, hemoglobin A1C, blood sugar, cholesterol, everything, kidney function, liver function, and step and the ECG on the heart. And step 4 is treatment, symptomatic, which I will give through his veins a fluid that contains sugar, the insulin. And step 5, I will try to speak about diabetic clinic referral, because now you develop the complication, you need to refer to the diabetic clinic, and then safety netting, and that's it. Okay. Pneumonia patient refusing treatment. So it's a case of patient who has pneumonia refusing treatment. Same approach, same cases. So you are an F5 to doctor in the medical department. Jack Smith, 78 years old, admitted 2 days ago with pneumonia. He is receiving IV antibiotic. IV antibiotic. IV antibiotic. He has heart failure 3 years ago, for which he is also taking medication. He does not want to take his medications anymore. So the station here is refusing medication. The patient is refusing to take his medication. He's diagnosed pneumonia, for which he is in the hospital, and also he is refusing to take his other medication. This patient is diagnosed heart failure and is on other medication and is refusing it. Don't forget, a patient is refusing to take his medications. A patient is refusing to take his medication. And when you tell him about the risks, you can say to him it can lead to death. Don't forget to address the mood, because he can be low mood, for which it's like suicide. Don't forget to address the psychosocial. Who do you avoid? How's things at home? Maybe he's getting abused. Maybe he's not happy at home, for which it's like suicide, because he's refusing his medication. So, hello, I'm Dr. Fatih Al-PLAB, one of the doctors here. They confirm your full name and date of birth. He will confirm. I can see from my note that you had pneumonia 3 days ago and you've been admitted in the hospital for chest infection. Yes. How's everything with you? How do you feel now? How's the hospital stay? How is the care by doctors and nurses? Rapport. Then the patient will say to you, doctor, I don't want to take my medications. I don't want to take my medication. Then it's a refusal structure for taking the medication. May I ask why? He will tell you, doctor, I don't want to take my medication. May I ask why? I just don't want to take it. May I ask what medication? So now you are trying to check what medication you're talking about. He will say to you, all my medication, doctor, my medication for the heart failure, my medication for the cholesterol, I don't want it. May I ask why? Doctor, this medication makes me tired all the time, make me drowsy all the time, I don't want it. Then start to address the concern. Addressing the concern, his main concern is it's making me tired, it's making me lethargic, it's making me drowsy. Address the concern. I totally appreciate your concern. Then step, address concern. I totally appreciate your concern. Tiredness can be caused by many reasons. So we can run some investigations, we can run some blood tests, and we find the reason why. We also can go over your medication to check what medication can cause tiredness, and then we're gonna stop it. So now I'm trying to address his concern by saying, well, you are right, medication can cause tiredness. We can run some blood investigation to exclude any other causes of tiredness, and we can review your medication. Then the patient, no doctor, I don't wanna take it. I wanna spend some quality of time with my daughter. Not quantity, guys, quality of time with my daughter. I don't wanna take this medication anymore. I appreciate your feeling. How is your daughter? How is the relationship with her? Yes, it's good, but I don't want to take the medication. Now, I will talk about the benefits. In the notes here, it's mentioned risk before benefit, but it's better to mention benefit before risk, okay? Then I will talk about the benefit. If you take this medication, why do we take it? It will improve your quality of life, okay? And with your daughter, who is concerned about you, it will control your symptoms. No, I don't want to take it. Then scare him. So when I scare him, I will say to him, do you know, Mr. Alex, what you're having? So assess his knowledge, yeah? Do you know what you're having? Because before you scare him, you need to know that he knows about his condition. You have heart failure. Yes, doctor. Unfortunately, the heart is not pumping enough blood, or is unable to pump the blood to the body. Yes, and if you don't take this medication, that can lead to serious consequences, and I'm afraid it can be life-threatening. No, doctor, I still don't want it. So you can assess his mood. How is your mood? How do you feel? How's everything at home? How is your life going on? Is there anything you think you can do? He's still refusing. Senior, I can talk to my senior to come and discuss with you. Maybe he will be in a better position of explaining things. No, doctor, discharge against a medical advice, and that's it. And always safety net the patient. But at any moment he accepted the medication, then he accepted. You don't need to carry on, okay? Now, cancer patient refusing chemotherapy. Again, it is similar concept to the previous one, but he is refusing chemotherapy. So, you are an FY2 doctor in the oncology department. Michael Robert, 82 years old, admitted 2 days ago with sepsis. So the reason why he's here is for sepsis. Like the previous case, he was here for pneumonia, but he's refusing his medication, which is long-term heart failure medication. This patient is here for sepsis, but he's refusing cancer medication. So he's been diagnosed with cancer and he's refusing the medication. So he was diagnosed with lung cancer 8 months ago. he's receiving chemotherapy. Cancer has shrunk, very important finding, yeah? Cancer has shrunk after chemotherapy, but he's still refusing. Then I will start my approach. Hello, I'm Dr. PLAB, one of your doctors here. Can you please confirm your full name and date of birth? He will confirm. I will say to him, I can see Mr. Michael from my note that you've been admitted here in the hospital for 2 days, 3 days, whatever is written here. Yes, doctor. How's the hospital stay? How's the care by doctors and nurses? Then start by targeting his concern. So you will say to him, I understand that you have some concerns. I'm here to address them. Yes, doctor. So he will say to you, doctor, so have anybody explain to you, always assess knowledge here, yeah? Yes, doctor. Yes, I don't want to take my chemotherapy medication. That's his concern. I don't want to take my chemotherapy medication. I don't want to take my chemotherapy medication. I'm not keen on it. That's his main concern. I'm not keen on my medication. I totally appreciate your concern, but may I ask why? He will tell you the concern. It makes me tired, lethargic, it is painful procedure having this medication, chemotherapy, and I cannot bear with it. Well, I totally appreciate your concern. I can see it is quite challenging. I can see it is quite tough. It is tough having these medications, and yes, it does affect your immunity, and it does cause you to have such symptoms. But assess knowledge. Do you know what you have, Mr. Andrew? Do you know what you have? Do you know what you have? Do you know the condition that you have? No, doctor. Then explain to him. You've been admitted here with neutropenic sepsis. You've been admitted here with neutropenic sepsis, which is decrease in the white cells that basically fight against the infection. So we have on our body white cells that fight against the infection. There is decrease in the number here, and that's why we are giving you antibiotics through your vein. Antibiotic through your veins. Yes, doctor. And I can see from my note that you've been diagnosed with lung cancer. Yes, doctor. And you are in chemotherapy. Yes, doctor. So now because he's refusing chemotherapy, you will tell him, is there any change in your medication? Is there any new concerns? No, doctor, there's no new concerns. But he will tell you, but I don't want the chemotherapy. Then you will tell him the benefits. Do you know the benefits of giving you chemotherapy? Do you know why we give you chemotherapy? Yes, doctor, we give you chemotherapy because it can lead to shrinkage of the cancer, and it can prevent the cancer from spreading. Yes, doctor. Yes, doctor, but I don't want to. Then, rest. You know what will happen if we don't give you chemotherapy? No, doctor, what will happen if we don't give you chemotherapy? The cancer cells will spread and they will go to different parts of your body, and that actually is life-threatening. It will worsen your condition. Then he's still refusing. Then escalate to senior. I can talk to my senior who can come and speak to you and maybe try to convince you about it. Still refusing, then discharge against the medical advice. But in this case, because he is refusing a medication that is leading to worsening his quality of life, you can ask about his mood. As I said, how is your mood? Who do you live with at home? Because this patient, I am telling him, if you don't take this, you will die, and he's still refusing. So then make sure you basically, in these cases, talk about psychosocial, because this is like suicide, as if it's suicide, okay? So I will jump to the other two cases, which are similar. Patient refusing cancer breast and refusing treatment. So you are an FY2 doctor in the GP clinic. Mrs. Tanya Jones, 38 years old, diagnosed the breast cancer in the GP, yeah? Diagnosed the breast cancer. She's scheduled for breast surgery after 2 weeks. She's calling you because she has some concerns. So this patient is calling the GP because she has some concerns. She's been diagnosed with breast cancer and she's having surgery in 2 weeks. So, hi, I'm Dr. PLAB, one of the doctors in the clinic. Can I please confirm your full name and date of birth? Full name and date of birth. Because it's a phone consultation, go back to the phone consultation structure. Is it suitable time to talk? Could you please give me the best phone number? So in case the line is hang up, or in case the line cut off, I can call you and then start your station. So always phone consultation approach. So because it's a phone consultation approach. There's an approach for talking in the phone. Start with it. Then, how can I help you today? Doctor, I don't want surgery. Right away, definitely, we cannot force you into having the surgery, but may I ask why? I'm not feeling, doctor, that surgery would help me. If I have it, I will die. So that's her main concern. Why don't you want surgery? She's saying, I'm not feeling that surgery will be beneficial. If I have it, I will die. You need to address her concern. Why does she think so? So, may I ask, I totally appreciate your feelings. I'm sorry about what you feel, but may I ask why you are thinking that if you have the surgery that you will die? Yes, doctor, that's what I feel. Have you encountered anyone who had surgery, such surgery, and died? No, doctor, I don't want, because if I have this surgery, I will die. You will say to her, I appreciate your concern. I can see where you come from. I can see how you're feeling. But many people around the world have breast cancer, and they had surgery, and it was successful. No, doctor, I don't want to. So I read her concern, and still she doesn't want. I will assess her knowledge. Do you know what you're having? Okay, do you know what stage of cancer you're having? She will tell you what stage of cancer, or do you know, has anybody explained to you about the condition? Then assess her knowledge. Then you will come and tell her, do you know the benefits? Do you know the benefits of having such surgery? No, doctor, if we do surgery, that will improve the outcome of the disease. That will improve the outcome of the condition. You will have a better quality of life. So that's the solution, and it even can prevent the cancer cell from spreading to the rest of the breast and spreading to your body. Then, no, doctor, refusing. Do you know the risks of not having surgery? Do you know what will happen if you don't have surgery? I'm afraid the cancer will grow and it will spread to the rest of your body, and it is life-threatening. So surgery is mandatory in this case. No, doctor. Clay, would you like me to talk to my senior who can come and talk to you and he will be in a better position? No, doctor. Discharge agent advice. So, well, definitely I can give you some time to think about it. Retain your information. If you have any concerns about the surgery, if you have anything, you can ring us again, or you can speak to your specialist. What if the patient at any time he accepted, then start the station by having a medicine station, which breast is affected, weight loss, and took some medicine, take some history about the condition. Okay, so in this case, you will basically say to her, we'll refer you to the surgeon, because maybe he can be in a better position in talking to you about the surgery. And if you have any concerns about the surgery, again, your consultant can address it. But be careful in this case, because she is refusing something that can lead to death. So please always assess the mood. Always assess the mood. Psychosocial. How is your mood? How do you feel? Whom do you live with? How's things at home? So in order to assess the mood. And psychosocial. Prostate cancer, refusing treatment, same approach. You are an FY2 doctor, urology department, Robert Taylor, 74 years old, admitted with urine retention, catheter inserted, and Mr. Taylor has a history of prostate cancer. He wants to remove the catheter and go home. Talk to him, address his concern. So it's discussing about a patient who's admitted with urine retention. A catheter is inserted to relieve her urine. Mr. Taylor has past history of prostate cancer. Mr. Taylor doesn't want the catheter. He just wanted to be taken off, and he wanted to go home. Hello, I'm Dr. Fatsal Baba, one of the doctors here. May I confirm your full name and date of birth? Normal. I can see from my note that you've been admitted with urine retention. Yes. How is it now? I can see that a catheter was inserted. Yes, doctor. And the urine is relieved. Yes, doctor. Yes. How do you feel now? Yes, doctor. I'm fine, but I just want to go home. I want the catheter to be removed, and I want to go home. That's his main concern. I want the catheter to be removed, and I want to go home. Definitely, we cannot force you against this, but may I ask why? Doctor, I feel I'm okay at home. I feel I'm better at home. Then, well, I'm really happy that you feel better at home and you feel okay at home, but do you know the condition? Do you know what you have? No, doctor, assess knowledge. You had urine retention. You were not able to pass urine. Why is this, doctor? Do you know why this happened? No, because you have bladder cancer. You have prostate cancer that obstructed the bladder. That's why you couldn't pass urine. Yes, doctor. Do you know what will happen if we remove the catheter and send you home? No, doctor. But you can talk about the benefit first. Do you know the benefits of having the catheter? Because he is refusing catheter. So the condition here is no catheter. He doesn't want the catheter. So you know what will happen? No, in a couple of days, you will come back to the hospital with the same problem, and it can lead to infection, and it can lead to serious consequences. No, doctor, scare him, and tell him the benefits. So the benefits is that being here in the hospital, we will be able to relieve your urine, and the catheter will remain for a few days, and you will even try to remove the catheter after a trial. So what we call it, trial without catheter. So we'll make sure that before we send you home, that you're not gonna have this condition. But that's the benefit. The risks, if you go home, you will have the same problem again, and you may be having urine infection, for which it can affect the whole of your system, and it can spread to your blood. Still not happy? Senior, discharge against the medical advice. And you can even discuss, and I can see from my note, do you know why you're having this cause? No, because I can see that you've been diagnosed with prostate cancer. That may be the reason why it's compressing, or it's causing some compression on the bladder. So as simple as, what is the station? Refusing a catheter. That's it. So why? Address the concern, assess knowledge, tell him about his condition, the benefit of staying, the risk of going. Okay? Okay. Okay, there is another case, which is a patient who is refusing colonoscopy. You are an FY2 doctor in the A&E, Jack Green, 72 years old, brought by the ambulance because of what, doctor? Because of what? Because he fainted. Full blood count was done, showed low hemoglobin. Consultant decided to do urgent colonoscopy. So this patient is planned for colonoscopy. Why? This patient fainted. When they did the full blood count, they found that it's low hemoglobin. So he was having most probably bleeding, PR bleed. And then the consultant decided that a colonoscopy is needed. So now you understand, yeah? Colonoscopy is needed, camera test is needed. The patient was dizzy and fainted. When they did the blood, it was low hemoglobin and most probably PR bleed, yeah? So this is refusing colonoscopy. Same, guys. Why do we use colonoscopy? It's a camera test. We'll check the reason why you're bleeding, and we take tissue sample if we see any unusual tissue in the colon, and they try to find the cause. These are the benefits. The risk, you will carry on bleeding, losing blood, and it could be something sinister. That's it, okay? So I'm Dr. Fath Al-Bab, one of the doctors here. Can I please confirm your full name and date of birth? He will confirm full name and date of birth. I can see from my note that you were brought by the ambulance because you were dizzy or you fainted. Yes, doctor. Yes, doctor. My consultant has planned because you were dizzy or you fainted. Yes, a blood test were done that shows that your hemoglobin is low. Yes, doctor. By any chance, do you have any bleeding from anywhere? So ask him about bleeding source. Yes, doctor. I have bleeding from my back passage. So by any chance, are you having bleeding from anywhere? Because you are trying to find the reason why. Yes, doctor, I have bleeding from my back passage. Since when? How did it start? Track. Timing, amount, okay? Any weight loss, any lumps or bumps anywhere in the body? No, doctor. So ask him about bowel habit, alternative bowel habit, medical conditions, and medication. And that's it. This is your history. So your history is, I can see from my note that you fainted. Yes. Yes. So when did it happen? Doctor, it happened like a few hours ago. Okay. Is there any way, by any chance, blood loss anywhere? Yes, doctor. From my back passage. Track is timing, relation, amount, color. So you are exploring that bleeding. Then, by any chance, do you have any bleeding anywhere else in your body? No, doctor. I don't have any bleeding anywhere else in my body. So ask about flows and the alternative bowel habit. Alternative bowel habit, constipation and diarrhea. Alternative diarrhea and the flows. Fever, lethargic, and appetite, low appetite, weight loss, night sweat. Then move on to my consultant decided, or my consultant think that colonoscopy is the procedure for you in order to know what's happening. No, doctor, I don't want colonoscopy. I don't want colonoscopy. May I ask why? Or you can even say definitely. We cannot force you on this, but May I ask why don't you want to colonoscopy? Doctor, I'm sure it's something uncomfortable. Then ask him about assess knowledge. How much do you know about colonoscopy? How much do you know about colonoscopy? Then the patient doesn't know, so explain to him. Explain to him. It's a camera test. Flexible tube attached to camera on top and source of light. So it's a flexible tube that has camera on top and the source of light. And this flexible tube attached to a TV screen. This tube will pass it through your back passage in order to see the entire of your colon, in order to detect if there is any unusual tissues. And you can take tissue sample. Doctor, but it will be uncomfortable. Doctor, but it will be painful. Then address his concern. So after assessing his knowledge, assess his concern. So yes, I totally understand where you're coming from. We will give you some sedative. We'll give you numbing gel so you will not feel pain. Yes, doctor, but I still don't want the benefits. Do you know why we're doing this? No, doctor, why? Because we need to see the source of bleeding. So we need to see the entire of the colon and see why you are having such bleeding. And we will try to exclude any serious condition. Okay, we'll try to check if there's any unusual tissues. We can take a tissue sample to define or to know what is happening. No, doctor, I still don't want the risks. Do you know what will happen if you don't have it? No, we may miss, or we may risk missing something sinister. We may risk missing something serious that can be prevented now. Also, that will lead to continuous blood loss and you can faint again, and that can lead to serious consequences. Okay? Okay. Then, doctor, I don't want to still. He still doesn't want. Then escalate to senior and that's it. Okay? Okay. I will discuss one last station about DNAR. Okay, DNAR. So I will discuss a scenario about DNAR. DNAR. We know the structure. I will take the structure off. Okay. There is something called DNAR. DNAR, which is do not attempt active resuscitation. Do not attempt active resuscitation. Do not attempt active resuscitation. And there is DNCPR. And there is the DNACPR, which is do not attempt CPR. CPR, which is cardiopulmonary resuscitation. I don't know if this is back in Egypt or not, or in Pakistan, India. There is something called do not attempt CPR, which is chest compression, cardiopulmonary resuscitation, and do not attempt active resuscitation. So there is two things. Some patients where if they need CPR, if they need a chest compression, we don't do it. And some patients, if they need a chest compression and if they need active treatment. What is active treatment? Antibiotic through their veins or any active treatment, IV steroids through their veins, we don't do it. So some patients only have a form signed, which is if they needed CPR, we will not. And some patient, if they needed CPR, we will not. And if they need active treatment, we will not. So be careful. There is two things. There is patient that we will not do CPR only, but if they need active treatment, we will give active treatment like IV antibiotics, like IV steroids. And some patient, we will not give active treatment. Sorry, we will not do CPR, but we will give active treatment. So it's DNCPR. So there is DNCPR and there is DNAR. DNCPR, do not attempt CPR only. If they need active treatment, you will do. DNAR, do not attempt active resuscitation. So if they need also active treatment like IV antibiotic, IV steroid, we will not give. Okay? Okay, so before anything, we know that this kind of cases that if the patient does not want CPR, if the patient does not want CPR, if the patient is refusing CPR, again, it's like the patient refusing something that will bring him back to life if he's dead. So it's like suicide. So in this case, he has the right. He has the right. He has the right. Yes, definitely. Definitely, you can sign this. If you need it, you will not have it. However, you must first ask about mood. Before the mood, you must first ask about, do you know what DNA CPR is? You need to assess his knowledge. You need to know that he knows what this is. I mean, why? Do you know the benefits? Do you know why we do this? Do you know what will happen? If you need it and we don't do it, you will die. You will die, ya brother, ya brother, ya brother, ya brother, you will die. So if he knows what CPR is, DNA CPR is, if he knows the benefits of it, if he knows what will happen if he needs it and we don't do it, so that means that he has mental capacity. That means that he knows what's happening. That means that he can make this decision. However, always ask about, have you discussed this decision with anybody else? Support system, who do you live with? How's things at home? How's everything at home? Ask about the mood. Ask about the suicide. Maybe this patient has issues like what? Maybe this patient at home, he needs support and care and it's not provided. If all these things are there, if all these things being asked about and you assured it, then he can sign. But by the way, there is two types of these decisions can be taken by us. A consultant can say, well, I think this patient, we need him to sign the form, the DNA CPR form, because if he needs it, if we do it, it will not add anything. That's one thing. So at this case, I will not ask about suicide. I will not ask about mood. I will not ask, because I am deciding. The consultant is thinking. But if the patient decided, it's a different case because he wanted. So I will assess his knowledge. Number one, do you know what DNA CPR is? Do you know the benefits of doing it? Do you know the risks of not doing it? Okay? And I will also ask him, have you encountered anybody who needed it? Maybe this patient has seen someone who needed it, and when they did it, it was so aggressive that it was so bad. So I will ask, have you encountered anyone who had such a procedure and maybe it was painful? Maybe he has any concern. Yes, doctor, my father had it and it was painful. My mother had it and they broke her bones. You must ask this. What's your background about it? What's your background about it? Have you encountered anyone who had such problem and who needed it, and then what happened? And then if you ask these questions, so the questions are, so before I do again, do not attempt CPR. Do not attempt CPR. Don't do cardiopulmonary resuscitation. It's a decision. If this decision is made by the consultant, because some consultant make this decision, there is no need for me to ask about suicide, no need to ask about mood, no need to ask about anything. I will only go to the patient, check his understanding about his condition, tell him about CPR, what CPR is, what will happen if he needs it and we don't do it, okay, and why do we take this decision. But if the patient is the one deciding, if the patient is the one calling me because he doesn't want it, at this case is different. Because he wants it. He wants something that if we do it, we will bring him back to life. But he would prefer that he will die. So in this case, I will add some questions. Mood, suicide, psychosocial, who do you live with at home, how's things at home, have you discussed this with the people that you love, and on top of this, I will do the same, which is assess knowledge. Do you know what is CPR is? Do you know what will happen if we don't do it? Why do you want us to do it? And the risks of not having it, okay? So basically, I will put here the D in CPR. So I will put number one, assess knowledge. What do I mean by assess knowledge? Check, ask the patient, do you know what CPR is? If the patient doesn't know, number two, explain in details. Explain in details what CPR is. Number three, do you know or have you encountered anyone who needed it? Yes, he will tell you yes, which in brackets, what's your background? In brackets, what is your background? Because for him to refuse it, maybe he has background, maybe he has an idea about it. So what's your background? Or have you encountered anyone who refused it? Okay, then, so assess knowledge, how much do you know about CPR? Explain in details what CPR is. Have you encountered anyone that needed CPR, and was it painful? Did you have any concerns? And then the risks, or no, the benefits of doing it. Why you do it? The risks if not doing it. The risks of not doing it. So if we don't do it, what will happen? And after telling you about the risks, which is death, the benefits, which is bringing you back to life when your heart or lungs stops, then ask about the mood, suicide, maybe he has no mood. Ask about psychosocial, who's at home with you, who's supporting you, who's at home with you. Have you discussed this with anyone close to you? What did they say? And finally, tell him, yes, we will sign it. However, it will need to be countersigned by a consultant. So guys, a consultant needs to countersign this. So I will sign it for you. A consultant will need to countersign it within 24 hours. So a consultant will further sign underneath. And then finally, safety netting. Safety netting means at any time you need to change your decision, you can let us know and we will be happy to change it. At any time you need to change your decision, you will let us know. So again, now I will be discussing about the NCPR. It is a station where the patient will ask you to go to visit him or her because they don't want CPR. In this case, when the patient doesn't want CPR, definitely we can help you with that. But why don't you want CPR? The first question. Why don't you want it? The patient will tell you, because I have a condition, doctor, multiple sclerosis, it's advanced stage. You know, the patient is having a chronic condition for which she's fed up. Is there anything you think we can do for you, that, or anything on our behalf that you think we can do for you? No, doctor, you did everything. But no, it's in the stage now that I don't want CPR. Then assess knowledge. Do you know what CPR is? No, doctor. Explain to her in detail. CPR is cardiopulmonary resuscitation. Basically, if your heart or lungs stops working, we'll jump on the chest and we'll start doing some compression to bring you back to life. No, doctor. Have you encountered anyone? What's your background about CPR? Have you encountered anyone? Maybe she encountered someone who had CPR done and it was painful. No, doctor, I just don't want it. Do you know the benefits of doing it? No, doctor. When we do this is to bring the heart and lungs back to life. The risks of not doing it, the heart or lungs, they will stop. Mood. So now I'm trying to ask, is there any other reason apart from her medical condition? Because her medical condition is valid enough reason for her to refuse it. Is there any reason, any other reason that, I mean, making you have this decision? No, doctor. How is your mood? If she's low, assess, ask about suicide. Psychosocial, who do you live with at home? How's things at home? Ask about carers. Is there anybody caring for you? Is there anything that we can do in terms of carer? We can provide you with carer. Doctor, I live with my daughter. Is she caring? She caring for you? How is the relationship between you and your daughter? So psychosocial. You need to exclude MAI. Maybe she's getting abused at home. And then very important, the question that we did not put here is, you remember the first 1 minute in this like DNA CPR? Is it only that you don't want to chest compression, or what about active treatment? So if we need to give you active treatment, if you feel ill and we need to give you medications through your veins, would you be happy with that? Yes, doctor, I will be. So she's only rejecting the CPR, which is the first 1 minute. We said there is refusing CPR and there is refusing CPR and the active treatment. This is the reason why I'm asking the question. Is it only the compression or compression and the active treatment? No, doctor, it's only the chest compression. Definitely, you can sign it. I will sign this for you. There is a form in the cubicle. It's in my notes. Very easy form. I filled it for you. And then you can fill it and you can say to her, the consultant will countersign this form within 24 hours. Finally, safety netting. At any time you need to change your decision, please let us know and we can do so. So this is the station, is about you are an FY2 doctor in the medical department. Maria Anderson, 85 years old, diagnosed with multiple sclerosis. She is an end-stage disease, end-stage multiple sclerosis. She asked you to go and visit her at home as she has some concern. So you go in the cubicle. When you go to the cubicle, as if you are visiting her at home. This question they say to you, she's asked for you to visit her at home. So you will go. I'm Dr. Fath Al-Bab, one of the general doctors here. Can you confirm your full name and date of birth? Yes. I can see from my note that you've asked for us to visit you at home because you have some concerns. Yes. How can I help you? Doctor, I don't want CPR. That's the start. That's the start. Before we discuss this, is it okay if we have a chat? Yes. So why don't you want CPR? Doctor, I don't want it because I have an end-stage condition. Multiple sclerosis. Yes. I can see from my note that you have end-stage sclerosis. And is there anything you think we can do for you? Is there anything you think we can do? No, doctor, you've done everything. You've done everything. Then start your station. What do you know what CPR is? Explain CPR. Have you encountered anyone? Benefit of doing it, risk of not doing it, and assess the rest of the questions. Because it's her decision. However, in my hospital, if it's my decision, I'm not gonna ask about mood and suicide because it is our decision to tell the patient about it, and it's our decision to tell the patient that you need to sign this because it's not gonna be beneficial. Okay? Thank you very much, guys. And we discussed the refusal structure and we also discussed the DNA CPR. And there is a form here. There is a form here, very easy form. In this form, you will fill the name of the patient, address of the patient, date of birth of the patient, and date of the DNA CPR. This form will be in the cubicle. If it's in the cubicle, you will have this filled already. So when you have this filled in the cubicle, so when you go to the cubicle, this will be already filled, the details. Make sure you confirm it. So make sure when you go to the cubicle and you have the form and these details are filled, confirm it's the right patient, then start filling. The first question, does the patient have capacity to make and communicate? Always press yes, and that's it. The second question, summary of the main clinical problem. So you will write down end stage multiple sclerosis because this is the condition. The third question, summary of communication with the patient. Patient wishes DNCPR. Finally, summary of communication with relative, not discussed because there was no relative here. And finally, names of the member multidisciplinary team, not discussed. Okay? All right. Thank you very much, guys. Thank you, and I will see you soon.